Hi everyone, I'm Rianne and this is my video presentation for NSPN 7155, the Breastfeeding Experience. Today I'm going to discuss the issue of a mother with flat nipples and a baby with jaundice. I'm going to work through the clinical decision-making framework. I will talk about the pathophysiology, some signs and symptoms of these issues, as well as some strategies to help both mom and babe. Looking at the decision-making framework, we'll start with knowledge, move on to cues, then judgment, then decisions, and then evaluation of outcomes. Starting with knowledge will allow us to get a bit of a background into both these issues in order to better support mom and babe. Flat nipples are flush with or don't stand out much from the areola and don't protrude when stimulated. Flat or inverted nipples may make it difficult for the baby to nurse. In women who are pregnant for the first time, it is very common for the nipple to not protrude fully. About 10 to 20% have some flatness or inversion. Flat nipples are those that are not visibly erect and is most often just part of the individual's genetic makeup. It is important to know that flat and inverted nipples are not the same. Inverted nipples retract or pull inward when stimulated. Because your baby forms a teat, not just for the nipple, but also for the surrounding breast tissue, most inverted or flat nipples will not cause problems during breastfeeding. During pregnancy, a woman's body removes bilirubin from the baby through the placenta. However, after a birth, the baby's body gets rid of the bilirubin on its own. The term jaundice is actually referring to the yellowish color of the baby's skin in association with hyperbilirubinemia, and occurs in roughly 60% of healthy-term infants. Hyperbilirubinemia is the buildup of bilirubin that is produced when red blood cells are broken down. All newborns have some elevation of unconjugated bilirubin. The newborn baby often becomes jaundiced during the first few days of life because the liver enzymes that metabolize bilirubin are relatively immature. Before babies are born, they need high levels of red blood cells in order to get oxygen from the mother's blood. Immediately after birth, when they begin breathing and having high oxygen blood, they no longer need their fetal hemoglobin. The red blood cells containing fetal hemoglobin now need to be broken down and eliminated from their bodies. Babies become jaundiced because they cannot process and excrete bilirubin as fast as they're breaking it down. In some cases, infants are more likely to become jaundiced if they have had a kiwi, forceps, or breech delivery due to the buildup of red blood cells and the bruising that will occur on their head or their buttocks. Other risk factors include premature babies, low birth weight, ineffective breastfeeding, and large weight loss after birth. There are 3 types of jaundice, and I will describe the main one. Physiological jaundice is the most common. It is not a disease, and it usually is not a huge worry, as long as the bilirubin levels don't get out of control. It is more prevalent in certain ethnic groups, with Asian populations being at the highest incidence. It develops between 72 and 96 hours and usually resolves within 1 to 2 weeks after birth. This type of jaundice is most commonly associated with ineffective feeding and therefore not passing stool to excrete bilirubin. The next step in this decision-making framework is cues. It is difficult to tell if a nipple is flat by just looking at it. Instead, you can determine whether or not the nipple is flat or inverted by doing a pinch test. By gently compressing the areola about an inch behind the nipple, if the nipple does not become erect, then it is considered to be flat. If the nipple retracts or becomes concave, it is considered to be inverted. Signs and symptoms of jaundice. The most common signs of jaundice is the yellowing of the skin. To properly assess this, the baby should be in natural light if possible. Jaundice starts on the head and continues to the feet as bilirubin levels rise. Blanching of the forehead or nose with a finger will determine a color change. The yellow may also be noted in the sclera of the eyes. A baby who is lethargic, irritable, jittery, not feeding well, and has a high-pitched cry may also show signs of jaundice. The most accurate way to test bilirubin levels is by a blood test. This is most often done with a heel prick and usually only necessary if clinically indicated. However, this is becoming a standard test for nearly all newborns. This graph is a great tool to tell if bilirubin is at a higher level than it should be, depending on the time of the baby's life it was taken. The next step in this process is judgment. So I want to look at what is going on in the relationship between mother and babe. I want to know a history of the birth. Was it traumatic? Was the mom able to do skin to skin with baby right away? I want to assess the baby's latch and see if it is able to latch to flat nipples and stay on. If it is not effective, I want to know why. Although jaundice usually doesn't show up for a couple of days, I am assessing this relationship right away so we can work on breastfeeding before issues arise. It is important to assess the mother's breasts after a feed to see if the baby was taking in enough breast tissue by the shape of the nipple and also signs of nipple breakdown. I want to assess the baby for lethargy and falling asleep at the breast, and keep in mind factors that may cause jaundice, such as bruising from delivery and gestational age. I want to ensure the baby is getting 8 to 12 effective feeds in a day, and ensure the baby is peeing and pooping enough. I need to evaluate the need for more help at this time. It is essential to be in contact with the midwife or GP when you notice signs of jaundice. 3 priorities for this challenge, for both mom and babe, are first, frequent and effective breastfeeding. Second, ongoing breastfeeding support to ensure effective milk transfer. And third, reassurance to the mom and family that breastfeeding is possible with flat nipples and jaundice is not a disease and can be easily treated. The next step in this process is decisions. Prevention and treatment is early and frequent breastfeeding. Ingestion of colostrum, which is a laxative, will increase stooling. Close monitoring of stools and voids are needed to ensure baby is clearing meconium. Assess infant's position, latch, and milk transfer. Encourage mother-infant skin-to-skin contact to promote breastfeeding frequency and stimulate a sleepy baby. We need to remind mothers that it is called breastfeeding, not nipple feeding. This may help them understand that their nipples aren't defective and gives them a visual of how much the baby really does need to get into its mouth. If the latch is not good due to flat nipples, it is best to see if the baby can pull it out first. If this doesn't work, there are ways to pull out the nipple to assist with a good feed. Breast massage and rolling the nipple between your fingers can help the nipple protrude out. Some women use a cold cloth to try to erect the nipple. There are also commercial products to help bring the nipple out with suction. Sometimes pumping the breast for a few minutes before a feed helps bring the nipple out. If the baby is unable to effectively breastfeed, it is a good idea to get mom to hand express EBM and pump depending on the circumstances to ensure the baby is getting milk. If a bilirubin is drawn and the level is quite high, phototherapy might be an option. This consists of exposing the infant's skin to blue light, which is breaking down the bilirubin into smaller parts so it's easier for them to eliminate it through urine and feces. There are 3 types of phototherapy options. The BiliSoft, which allows the mother to hold the baby and breastfeed at the same time. The single unit or conventional unit, where there is only one light on the top or the bottom. And the dual system with lights on both the top and bottom for those whose bili levels are quite elevated. Infants are usually naked or only wearing a diaper. They need to always be wearing eye protection, and it is strongly encouraged to continue breastfeeding throughout this therapy. Phototherapy increases the fluid requirements of the baby, just another reason to make sure you have effective and frequent breastfeeding. The next and final step is evaluation of outcomes. To evaluate if this care was effective, I want to see an increase in stools and voids, as well as a transitional stool to a mustard yellow. I want to assess the awake state of the baby while feeding and ensure that the baby is more vigorous at the breast. The jaundice color of the skin should also be improving, and I want to ensure the baby is gaining weight. I want to continue to monitor the breastfeeding dyad and provide more experienced support if necessary. To wrap up, a mother with flat nipples can most often breastfeed with support. Keeping an eye on signs and symptoms of jaundice is important for early recognition. The most important treatment for jaundice is effective and frequent breastfeeding, and in certain circumstances, phototherapy may be required. If women continue to have troubles with the latch due to their flat nipples, express breast milk may be needed to nourish the baby. If this is the case, increased support from a lactation consultant is needed to ensure breastfeeding can be established and maintained.